Dear Chair, dear audience, in the upcoming few minutes I would like to present our 15th month progress. My name is Kinga Kovács and currently I'm a pediatric resident at the Department of Semmelweis, Department of Obstetrics and Gynecology at the Neonatal Intensive Care Unit. Our vision is that the focus in neonatal care should be on eliminating as many complications of prematurity as possible. That's why our mission is to investigate perinatal risk factors. To achieve these aims, here are our specific projects, scientific projects. The first two is related to the histopathology of the placenta and the umbilical cord, and the third one is related to the apnea of prematurity. Our first project is a systematic review and meta-analysis investigating the prognostic role of fetal inflammatory response. First, I would like to give some explanations to these terms. Chorioamnionitis means the inflammation of the chorioamnionic membranes. This is the maternal part of the placenta, so this is the part of maternal inflammatory response. And as this inflammation progresses to the fetile direction, it causes chorionic vasculitis and phoenicitis, and these last two is the part of fetal inflammatory response. Intrauterine inflammation is one of the leading causes of preterm deliveries, and several studies, meta-analysis has already showed association between chorioamnionitis and different adverse outcomes of prematurity. However, the impact of fetal inflammatory response is unclear. That's why our aim was to investigate the role of additional fetal inflammatory response. Our population contained preterm neonates and very low birth weight neonates, and in the exposure group we included neonates with chorioamnionitis and fetal inflammatory response. Meanwhile, in the comparison group there were neonates with chorioamnionitis alone. In the end of the selection process, we had 47 eligible articles. Amongst we had 23 that used more strict, more homogeneous histological classification. And that's why we had random analysis both on the smaller group of articles and both on the whole pool as well. And I will note if there were any difference between the two analyses. Here is the list of our outcomes. These are the major morbidity of prematurity. One of our primary outcomes is mortality. And as you can see, we conducted a subgroup analysis as well using the mean gestational ages of the studies. And we created one with higher and one with lower gestational age using the cutoff line, the 28 weeks of gestation. And according to this 16 study, we found no difference between the comparison and the exposure group. Early onset sepsis is sepsis occurring within the first 72 hours of life. And we found a non-significant elevation of incidence of sepsis among neonates with fetal inflammatory response, and we found similar tendency in case of late onset sepsis. Bronchopulmonary dysplasia is a chronic respiratory morbidity of prematurity, and here we also found a non-significant elevation of the incidence of BPD among neonates with fetal inflammatory response. However, conducting this analysis on this smaller, more homogeneous group of articles, we found this elevation to be significant among neonates with lower gestational ages. We analyzed also several neurological outcomes as well, and in case of intraventricular hemorrhage, we found a significant elevation of the incidences of IVH among neonates with fetal inflammatory response. However, this significant difference could not be demonstrated in case of analyzing only the severe intraventricular hemorrhage. We analyzed one maternal outcome as well, clinical chorioamnionitis. That means clinical symptoms prenatally, like maternal fever or uterine tenderness, and we found it to be threefold elevated among infant mother diets with fetal inflammatory response. All in all, we can say that the strength of our analysis is that we use studies with histological confirmed chorioamnionitis, and we have this selected subgroup of articles with more homogeneous histological classification. But just as important are limitations, that in certain articles, the outcomes are based on slightly different criteria, and these outcomes are multifactorial, highly influenced by different confounding factors such as gestational age or mortality, and we collected only unadjusted data. in conclusion, we can say that we found no difference or no tendency in vast majority of the cases. We found association between fetal inflammatory response and intraventricular hemorrhage, and in case of extremely preterm neonates with bronchopulmonary dysplasia. And our analysis showed that chorioamnionitis with fetal inflammatory response is clinically much more apparent than chorioamnionitis alone. Our implication for practice is that regular histological examination of the umbilical cord should be incorporated into our everyday practice, and the results can be included into our prognosis evaluation. And since we found only a tendency in case of early onset sepsis, we can draw no clear conclusion in terms of antibiotic therapy. Our implication for research is that it would be important to identify the possible pathways of the progression of intrauterine inflammation and the role of fetal inflammatory response in the clinical picture of chorioamnionitis. And during conducting these meta-analysis, we met similar problem like other meta-analysis with this delicate population, that knowing the confounding factor would be essential. And the closest we could get to control these confounding factors would be with meta-analysis of individual patient data. And we have sent our manuscript to internal review, and currently we are publishing it according to the suggestions. Our second project is a cohort analysis based on really similar people like our meta-analysis. In this case, we will include preterm neonates born before the 32nd gestational week is completed and born at the first department of Obstetrics and Gynecology. And here we have another comparison group, one with negative histological results. We will collect data between, in the period between 2020 of January and 2022 December. And currently we are finalizing the data table and starting the data cleaning. Our third project is a protocol of a randomized control trial, the effect of additional pre-extubational loading dose of caffeine citrate. One of the most common indications for intubation or intubations are frequent episodes of apneas. And since the CAP trial, there is an evidence that caffeine administration reduces continued apnea and associated with shortened duration of ventilation. Nowadays, there is a tendency towards non-invasive ventilation because of the consequences of mechanical ventilation, such as BPD or reduced lung function. But there are cases when mechanical ventilation is inevitable, and in these cases, we try to remove the endotracheal tube as soon as possible. And this period, this peri-extubational period, is quite vulnerable period of the neonate because there is a reasonable chance for reintubation because of these above-mentioned apneas or decreased spontaneous breathing. That's why our aim is to investigate the effect of a higher level of caffeine in this quite short, quite vulnerable period of the neonate, the peri-extubational period. Our clinical question is that does additional loading dose of caffeine citrate 1 hour before planned extubation reduces the extubation failure? Our population will contain preterm neonates born before the 32nd gestational week is completed and had been mechanically ventilated for at least 48 hours. Our intervention will be an additional 20 milligram per kilogram loading dose of caffeine citrate 1 hour before extubation. Our primary outcome is reintubation within the next 48 hours. Our implication is that caffeine can decrease extubation failure and mechanical ventilation days, and thus BPD, and this study can contribute to finding the optimal dosing regimes. Here are our eligibility criteria, both inclusion and exclusion criteria. And beside our primary outcome, we have secondary outcomes as well, like frequency of apneas, heart rate, or gastric residuals. And this summer we submitted the ethical approval, but it had been forwarded from TUCAP to ODE, and we have done the EUDRES CT application this week, and we are doing the documentation for ODE. Here is a quick overview of our planned studies and the planned submission dates as well. Thank you for your attention. I brought a quote for the tiny ones. From a tiny spark may burst a mighty flame. Thank you.
Have you already changed your clinical practice based on the results coming from the first study of you? And my second question would be that maybe you have mentioned, it was just me who missed it, what is the practice at your institute according to the caffeine dosing, and how do you treat this tiny kids?
Thank you for your questions. Firstly, actually, we didn't change our protocols regarding the histopathology of the placenta and the umbilical cord, because since 2020 we have this protocol to collect all the data and have the results pretty soon. So, and we have an extra slice from the umbilical cord really close to the baby, so from the fetal end. And we can include into our prognosis evaluation those results. And as for the second question, in the first day of life, we usually start with the loading dose of caffeine citrate for all preterm born before the 32nd gestational week is completed. And then we use the maintenance dose every day. That's 10 milligram per kilogram. And our study would give an additional loading dose before the extubation.
And what is the loading dose?
20 milligram per kilogram.
Okay, thank you.
I have not been aware. So do these babies get actually the caffeine from every day? They get it when they are preterm born. Am I right?
Yeah. Yes.
Any adverse events that you have found with this?
Yes, there are adverse events. For example, elevated heart rate or elevated gastric residuals of the babies, and but we will collect those data as well.
Your third project that you had a long delay because of the authorities are actually sending stuff to each other. So can you tell us what was the problem, or that who was thinking about this, or what? I mean, I also had experience of kind of delaying things.
To tell the truth, I'm not really sure why it had been forwarded to OJI from TUCAB, and OJI needs a totally different documentation than TUCAB. And the documentation we already had, we need to rewrite them and need different application like EU DRAS-CT, we have to apply there as well. So it is long.
Okay, but I mean, if you really get it, I mean, I think then that's fine. I mean, well, this is the way of life today in the EU. Maybe that's not only my problem and your problem, but others' problems.